Allison?
Yes.
Okay, I'm clicking on show screen. Is it highlighted for you to do it?
No, well, I have access to it, but the other thing is I think we began the broadcast. Let me just check that are ready. Can hear us. Can hear us getting ready.
Okay. So good afternoon and good morning, everyone. Thank you for joining us and PointRight here for the first session of an educational series that myself, Pam Kaiser, part of the Senior Healthcare Specialist team, are pulling together for you as we enter this exciting time with the patient-driven payment model that's coming up next year. The first order of business is to let folks know that you are on mute and that we are going to be recording the session. So if you have a question or concern about being recorded, now is the time to drop off. And then also, as time permits, we'll be answering questions at the end of the session. So just type your questions into the chat box and we'll get to them as many as we can. And if not, we will put together a question and answer and circulate that to the attendees, as well as the slide deck. We'll be sending that out to you folks after the session is over. So let's go ahead and get started. So again, welcome to the series on PDPM. We're here, and the intention behind the series is to provide insight and information about the new methodology that's going to be coming to effect with the next fiscal year. And it's important to note that, we do have lots of information as we're doing more analysis and research into the subject matter of the final rule and the technical guide. We do get other information that comes to light, and so this information is as much as we know right now. And then as we move on in the series, as we gather additional data and do additional analysis on our end, we'll be sharing that with you at that time. The learning objectives for today are essentially be able to understand or list the components of the patient-driven payment model, or PDPM, to talk through sort of the assessments that are available to you at that time. A lot of the PPS assessments will be leaving us, which is a good thing, but there'll be other assessments that will be important for you to know about and understand as that will drive your reimbursement. And then also towards the end, we'll talk about some of the strategies that you might have or deploy while you're looking at PDPM in order to continue delivering quality care and make sure that you have the information and the documentation that supports the care that you're delivering. So how did we get to this point? It really has been no surprise for folks that watch reimbursement, who watch what's going on with CMS as with regard to rulemaking. It's nothing new, right? They've been talking to us for quite some time about wanting to change how they account for the delivery of services, therapy services in particular, and how they calculate that into the reimbursement for the providers. So what happened back in May of 2017 was this first thing that we had heard of called the Resident Classification System, or RCS1. And this was their first attempt to address their concern about therapy delivery, and how SNFs are reimbursed for the care that they provide. And the goal behind the classification system, RCS1, was actually threefold. One, they wanted to make sure that they were getting accurate compensation for the SNFs, so that services that we were providing, we were appropriately getting paid for. They also wanted to look at this behavior, this sort of seemed to be the incentives that were embedded within RUGs that seem to cause SNFs, or cause the behavior of delivering therapy based on financial considerations in their perspective, more so than what was just they deemed to be resident need. And the other goal was to I kind of laugh, maintain simplicity, but probably more to increase some simplicity when it comes to trying to figure out how folks are delivering care and being compensated for that. And so, as you can probably imagine, when this first proposed rule came out with RCS1, there was lots of industry comment and feedback. And what happened was CMS actually prolonged the decision-making process. They expanded the feedback, the comment period, because the comments were so voluminous and important. So they really, made some changes that prolonged that process. The next thing that we saw was, many months later, in March of 2018, they were talking about this in an open door forum, as they frequently do, and they indicated that they really hadn't got anywhere near to finalizing the policy for RCS1. They were still looking at feedback and taking under consideration a lot of the information that they were given. And then also they were asked about this concept of a unified post-payment or post-acute care payment model. Sometimes we hear it called a site-neutral payment, which was in fact codified or required when the Impact Act passed. And CMS did acknowledge that that was one of the things they were kind of struggling with, was to try to create a payment methodology that would lead as a first step to this site-neutral or unified post-acute payment methodology. So they came up with PDPM for us, and basically the idea behind it is that they really wanted to look at the resident, at the patient, as the entity that was driving the care that's delivered. They wanted to look at verifiable patient characteristics and specific, resident diagnoses, not this idea of paying us in the amount of therapy that was delivered. So conceptually, it's bringing the resident back into the main focus of what we're doing when we're providing care. In addition to that, they wanted to look a little bit more at the ancillary costs beyond therapy services. As we all know, RUGs, you have everybody, the majority of folks wind up in a rehab category, and you may have two people that RUG into the exact same RUB, RUC, RVB, whatever category, but their profile, the cost that it is to us and to you to provide services to them is very, very different. So they wanted to look more at these ancillary costs and things that drive up the cost for providing care to residents and account for them in the payment methodology to SNFs. They took pity on us with all the assessments that we have to do right now, and determined that they could use fewer assessments to establish rates for payment. And they introduced this concept of rate adjustment that happens automatically over time. It's relatively new to us, but it's not new to other post-acute payers environments. And the other thing they wanted to include, that is included, is more case mix components when they're delivering the final payment for us, that they're considering additional case mix components in that calculation. And here is kind of the icon for the PDPM wave, as it were. The resident rate is determined by these other components, broken down into PT, OT, and speech. So the therapies are segregated. They are including nursing, non-therapy ancillaries, and non-case mix. And all these case mix components wind up getting added together with a little bit of other math, and they result in the resident rate of payment. So let's break this down, starting with the PT-OT component case mix portion. And the basis for this, for both of them, is really the clinical reason for the resident's SNF stay. Or in other words, what's the primary reason for the SNF, for the resident to be in your SNF? And where that's going to be entered in on the MDS is in I-8000, right here. So if we look in I-8000 in that first box, that's where we'll be entering the primary reason for the resident or patient to being in your SNF. And then the second element that we're going to be looking at, or will be looked at, is whether or not a prior surgery was included. And folks that have looked at the new MDS item set will notice that at J2000 there's a question about whether or not there was surgery in the last 100 days or not. And what they're going to do is enhance that in order to add whether or not there's been a surgical procedure during the prior proximal hospital stay. It probably won't have those words exactly, but the concept is to really understand if in the prior hospital stay the resident had a surgical procedure, and then that will be captured on the MDS in order to be included in your OT and your PT case mix adjustments or components. Now, they also said that the initial encounter could be included as part of, or as the primary case mix. And there was some question about that or conversation about that, because typically the initial encounter for DRG happens in the hospital setting. But again, CMS is reiterating that it's the reason why this resident or patient is in your SNF. And so it could very well be that there is a condition or concern that arises in the SNF that would require an initial encounter. And so in that case, if that's the primary reason, then you'd want to include that if you did an intermittent payment assessment, which we'll talk about later. But the concept here is that an initial encounter can be used as the ICD-9 code for the primary reason for a resident in a SNF. And we had moved away from this acute care coding methodology or concept in that, when a resident came to us, they weren't in the acute stage as they were in the hospital. And what CMS found when they went to do research is we had these after codes, and a lot of them had to do with, a delivery of rehab. And so there wasn't a lot of information that they had in the system to be able to do any analysis with regard to ICD-10 coding in the SNF. So what they did say was that the acute care codes are back, particularly when the treatment is for a current acute disease. So if there was a fracture in the hospital that they were treated for, that's the acute state, and they came to the SNF for that acute fracture care, that's what you'd be coding as the primary code for the stay. So ICD-10 codes have always been important, and they're increasingly more important when we start to look at the PT and OT case mix. Also important is the functional status on admission. Again, this section GG, which we'll talk about in a little bit, is where they're going to get that information for the functional status. And then in addition to that, for some components that are case mix components that roll into the resident rate, there's what we call an adjustment factor. And that essentially is based on where the resident is in their stay with you. And depending on what that day is in the course of their stay, an adjustment factor will be applied for PT and OT and in other areas as well. So what will happen is the diagnosis code, the primary reason for the patient being in your SNF, will then place the resident into one of 4 clinical categories. So they're looking at major joint or spinal surgery, non-orthopedic surgery and acute neurologic, other orthopedic, and medical management. And you'll see the first 2 indicate that surgery was involved. And so when CMS makes that adjustment in section J asking about surgery, it'll be important to code that up obviously correctly so that the resident will be placed along with that diagnosis code in the right category. When we look at the functional status on admission, the other element that goes into your another element that goes into your PT and OT component, case mix component, again, as I mentioned, we're looking at section GG for the calculation. And the rationale behind this is that this functional status, this type of functional status where we're looking at the resident's customary ability, is in better alignment with some of the other payment models that they have with other post-acute providers and with other quality initiatives that are going on writ large with CMS. Unlike Section G, when we start to look at higher points here, though, it means that the higher the points, the higher the independence level. So Section GG is looking at including the higher points for the independence levels. And if it's not deemed to be non-applicable or the resident refused or is not attempted, they're coded as dependent, which is a little bit of a pickup for us. Unlike the rule of three, this will help us because it does code them as more dependent. It includes a variety of elements. Some of them are mid-level loss ADLs, some of them are late loss ADLs, 2 bed mobility items, there are 3 transfer items, there's 1 eating item, 1 toileting item, oral hygiene, and then there are 2 walking items that are included. And here's the section of the MDS where that information is derived, and then the different scores. So what you'll notice is we have, an assortment of items that we're looking at. Some of them are scored individually. So we look at the components from 1 to 4 for the self-care items. And then in the subsequent mobility items, they're averages of 2 or more items at a time, which is an interesting method to use. One of the things that we know when we're looking at coding RUG scores now in Section G is sometimes you can look in the medical record and maybe pick up an ADL score, boost it up because you're able to pick another level in another time of more dependence. So an episode of dependence, that's the word I was looking for. And that may swing your ADL score into the next category. Whereas when you look at some of these groups here, you'll notice that you're averaging the two. And in some situations with those averages, it's harder to really affect a change, that quick of a change in an ADL score. So it's sort of smoothing out the highs and lows and aggregating the ability of the resident when we look at functional status on admission. And then the last element that's contributing to the PT and OT case mix component is this adjustment factor, or in the rule it's called the variable per diem payment. And the intent behind this is to look at or to catch how resource use tracks over a resident's stay. When they looked and broke down where the resource use happened, what they noticed when they looked at PT and OT is that resource use declined over the course of someone's stay, and we all kind of have seen that in practice. That there is this decline in resources as the resident continues with the stay in a SNF. And then the other analysis when they took a look at a lot of data was that the speech language pathology remained constant over time, that didn't have the variation that PT and OT did. And the other thing that they noticed was this non-therapy ancillaries, the NTA costs. They were concentrated really at the start of the stay and not as much as the stay progressed. And for folks that do, cost out analysis, who do that work, that sort of back of the napkin sketches, when folks come into your building and you're trying to get an idea of what the cost is going to be for those residents, you'll know that, at the very beginning of their stay, we're ordering the medications, we're ordering the equipment, we're doing the lab tests. All of these things that are going into providing care for the resident tend to be front loaded. And so we see the cost really high at the first part of their stay, and then it dissipates as the stay continues. So those costs are allocated or spread out over time over the course of their stay. And what was also noticed as they started to look for these 2 areas in particular was that the PT and OT costs were higher in the first 20 days of the stay. And that was sort of the marker when they really first started to see a decline in resource allocation. So between day 1 and day 20, the costs were higher. And then also for NTA at the NTAs, that was a little bit more truncated. It was the first 3 days. And so what CMS is doing in PDPM is applying adjustment factors depending on where in the stay a resident is, and they use that multiplier for those payments. So for the first 3 days of the NTA stay, you'll see this adjustment factor applied. So here's what the case mix actually looks like. You'll notice on the left-hand side, those are the clinical categories that the resident would fall into, which are further divided by their functional score for section GG. And then when we look at the case mix indices for PT and OT, you see that they do adjust, they do change over time. Particularly in the last 3, we see little utilization, lower indexes or indices on the end and the beginning of the stay, and more concentrated indices in the middle of the stay. What CMS had looked at was sort of this bell curve of a delivery of PT and OT, particularly in the last 3 categories. So here are your new clinical categories and functional scores and case mix groups for PT and OT. When CMS took a look at speech in relation to OT and PT, they sort of saw this inverse relationship, meaning that they didn't really track in the same way. And so what that necessitated was a completely different approach for speech than there was for the other therapies. And there were some similarities and some differences. And so like PT and OT, we did see a decrease in the clinical categories. For speech, there's essentially just 2 clinical categories, acute neurologic and then non-neurologic, which are all the other categories. So your other orthopedic, your other surgeries are included in the non-neurologic category. So similar to OT and PT, we have this reduction in categories, but unlike the other 2 therapies, speech looks at the presence of cognition, whether or not there's a swallowing disorder, mechanically altered diet, and then a count of comorbidities for speech. When we looked at cognition, what was found was that it was a strong predictor of costs for speech and not PT and OT, which was kind of interesting because a lot of times we would think that someone who's cognitively impaired would have a hard time following the instruction and participating in some of these other therapies, but that actually was not the case when the analysis was done. It was cognition was more closely related to speech than these other therapies. And what PDPM did was combine the BIMS, the brief mental status assessment for cognition, and the CPS, and they created their own sort of breakup of this cognitive measures. And in addition to being a strong predictor of cost, it didn't matter whether the impairment was mild or severely impaired. We did see changes in cost in relationship to that. So just the mere presence was enough to create this difference in the need for the inclusion or consideration of cognition when they were developing rates for reimbursement. So when PDPM indicates that someone is cognitively intact, mildly, moderately, or severely impaired, these are the corresponding BIMS and CPS scores that will put them into those categories. The other element, or other 2 elements for speech were the idea of the swallowing disorder or mechanically altered diet. Again, just like cognition, they contributed to the increased cost of speech per the stay. The more resources of speech were required when these elements were in place. Both of these are coming directly off the MDS. The swallowing disorder, which is K100. So if Z is coded or not will determine whether or not a resident is deemed to have a swallowing disorder for the purposes of PDPM. A mechanically altered diet, again, under nutritional approaches, we'll have the opportunity to code a mechanically altered diet, again, while a resident in the SNF. So both of these are coming directly off of the coding of the MDS. And the case mix could capture the presence of both, the presence of neither, or either one. We talked about this concept of some comorbidities for speech, and so there are some conditions or services that are delivered that are considered to be increasing the likelihood or the need for speech, and they're taken into consideration when we're looking at the case mix element for that. Here is the case mix. The case mix breakout for you. So we're looking at whether or not there's an acute neurological condition, whether there are comorbidities in place, and whether or not there's cognitive impairment. So again, you can have none, one, or any combination of those. And then this idea of a mechanically altered diet or swallowing disorder. As I mentioned, it can have neither, both, or either. You'll see the case mix group again, and then the indices that are associated with each of those. So that was just therapy. So I know you got this. We'll keep going. Moving into the nursing rugs, so similar. They'll look very familiar when you look at them, the breakout of the nursing groups, the case mix groups. They're very similar to the current nursing rugs, but they have been reduced. They're down to 25 possible groups. And one of the reasons why CMS believed that it was appropriate and acceptable to collapse the nursing groups is when they looked at some of the ADL groups, particularly the ones that were close together, that there was no more nursing time required between similar ADL grouping and residents that had similar conditions or clinical traits. So they were able to collapse some of the possible groups down in that manner. Within nursing, there's an accounting for additional nursing costs for those folks that have a diagnosis of HIV. Again, it's going to be important to make sure you get that diagnosis code on the claim in order to make sure that the information flows through to the reimbursement. And then, but it is accounted for within the nursing case mix. And then it's looking at, and they'll be looking at, the clinical information during the stay in order to put folks into the nursing case mix category. And similar to the therapies, this functional status is going to be important as well. So the functional status on admission, section GD, will be a key. Here is the nursing case mix breakout for you. So you'll notice on the left-hand side is the nursing rug as it stood. And then second from the end, you'll see the PDPM nursing case mix group. So some of them are similar. You'll see that, as I mentioned, they look similar. But you'll notice under the special care and the clinically complex, you'll see this collapsing of the two ADL categories, E and D. So once they qualify for that category, they reduced the number of ADL splits, but they still kept depression. So that will be important. And then when we get to the other nursing categories, where restorative nursing is key, that will be important to make sure we're capturing that as well. So here again are some of these combinations. HC1, HB1, again, similar nursing time taken for those types of residents, combining them down into the HBC1. And this continues into the other nursing categories. Again, down at towards the bottom here where we have behavioral cognition is where we see restorative nursing coming into play. And then in the other categories here, we see restorative nursing as well. So 25 nursing case mix categories based on the condition of how folks are in your center, the presence of depression, the use of restorative nursing, and your functional status on admission. When we look at the non-therapy ancillary case mix, again, as I mentioned earlier, there's this idea that, two folks that have the same rug category don't necessarily cost the same when you're taking care of a resident, right? There are costs that are hidden by the fact that they're in a rehab category, and so CMS wanted to account for that. Historically, this was folded into the nursing category, and just for clarity and for better resource allocation and better math, essentially, they've split it apart so that we can really see how this non-therapy ancillary case mix influences the rate and the resources that are used in providing care to these subacute patients. The top 50 conditions or services that were the most costly were identified. And so those were the ones that they're looking at when they're accounting for increasing or decreasing the case mix indices for the NTAs. So the top three, probably no surprise: the presence of a diagnosis of HIV or AIDS, folks that are getting tube feeding at a high level. And they do have a distinction between parental feeding IVs at a high level and a low level. The high level is 50% or more of the calories through those that either parental feeding or IV, and the low level is 25% or less, and 500 cc's of fluid. So that's how you would get into those categories. And then the special treatment, so IVs. So those are the top three. Here is the case mix, and what you'll notice is that number one, where's the information coming from? It's coming by and large from the MDS, with the exception of the designation of HIV or AIDS. So they want to make sure that that's on the claim. And then there's this concept of points. And so what happens is for each of these NTAs that a resident may have, we total up the count, and then that total segregates them into the case mix buckets, as it were. So here are the additional 50, top 50 costs. And here's the classification group, as I mentioned. So you'll notice it's a score range where they're summing each of those NTAs that the resident is coded for, adding them up, and that puts them into a bucket. So obviously, the more NTA resources that are needed, the higher the case mix. The non-case mix components, this fortunately is something that we're familiar with. It's not anything new. It's not case mix adjusted even, and it's intended to represent those costs that are in place for all residents, the fixed costs for running your center. So it's including room and board, it's capital expenses, and other fixed costs that would be part of that calculation. So what we're looking at here then is how to tie it all together, right? So we're looking at PT, OT, speech, nursing, NTAs, and non-case mix. And what's happening is there's a base rate that CMS is providing for all of these components. We're looking at the case mix adjustments, so those 1.16, 1.03, all those case mix adjustments are multiplied by the base rate. And then for PT, OT, and this non-therapy ancillaries, they're multiplied by the adjustment factor that's associated with where in their stay they are. Those are all added up together in order to derive the PDPM rate for that particular resident. Here's another way to look at the payment drivers in PDPM. So again, when we're looking at PT and OT, it's the primary reason that they're in the SNF. It's their functional status when they come into the SNF on admission and where in the stay they happen to be. When we're looking at speech, there's a little bit more involved. It's again, the primary ICD10 code, what their cognitive status is, the presence of a swallowing disorder or mechanically altered diet, and then how many comorbidities they have associated with that speech. In nursing, again, it's clinical information related to the stay, the functional status, extensive services makes a difference, depression and restorative nursing. And then lastly, it's your NTAs, which are the comorbidities and extensive services, which you see in those comorbidities and where in the stay they are. So let's take a look at the assessments. So the assessments are good and bad, right? We have some required and one that's now voluntary. The good news is that it's the same data set. They do make little changes, nuanced changes to the data sets every year. Sometimes it's just language, sometimes they add or remove particular elements or section, portions of the MDS, different test triggers. But by and large, it's the same MDS that we all know. The same assessments will always be required by OBRA. You still have to do the admission, your quarterlies, whether there's an annuals, whether there's a SIG change or SIG correction, your discharge assessments and your tracking forms. When it comes to PDPM, you're going to need to do a 5-day assessment and a PPS discharge assessment. Those are the only 2 assessments that are going to be required under this new system. So a great reduction in the number of assessments that will need to be done, right? No end of therapy, no start of therapy, no COTs rather. So that's all good news. It should definitely make it a lot more easy. The other thing is this idea of grace days, where we had days 1 to 5 and then we had the 3 extra days for grace days. They kind of done away with that. I mean, there really was no penalty or no reason to track those. So they just went ahead and added those to your 5-day assessment window. So you'll notice that it will be days 1 through 8. So they've eliminated the concept of grace days. And they've included this new assessment called an IPA, interim payment assessment. And we'll talk about that, but it's voluntary. So it's voluntary. The item set is the same item set as you'd see on the 5-day, so there's nothing new there, which is nice. There's 2 basic criteria that are used. One is rather long, one's a little bit shorter, so we'll start with the longer one. The idea behind it is to catch changes in the course of a resident's stay. And so what they're looking at, in order to do an IPA, there has to be a change in the resident's classification in at least one of the first tier classification criteria. So the first tier criteria are, PT, OT, speech, nursing, and the NTA. So you have to have at least a change in one of those so that the resident will be classified into a different component, so that when we did the addition of everything, that you'd see a different in the component from the 5-day that was already completed, and it would result in a change of payment, whether that payment was a payment component or whether it was the overall payment for the resident. So it's to capture these large changes that would result in a change in payment, number 1. And then number 2, the changes would have to be such that the resident would not return to their original clinical status within 14 days. So this sounds very much, to me at least, like a SIG change in status kind of qualification. So the first thing you'd want to do, I think, to make it easy is to do a quick assessment as to whether or not this resident was going to have the expectation to come back to the original clinical status. And if the answer to that is no, do the further investigation to see would the change in the category constitute a change in the first tier components, which would result in a change in the rate. Again, the concept behind the IPAs is to capture larger changes in the resident's clinical condition. That would mean a change in the use of resources and therefore costs. And really, the nice thing is CMS has not given any further direction on IPA criteria. They've left it up to the centers, but like a lot of other things, they did say they've left it up to the centers, but they would be paying attention. So, if bad actors are out there and they start to do a whole slew of these when it only goes in one direction and not the other, that kind of thing, they are watching. Again, with any of these new things, compliance, it will be important. So if we take a peek at the assessments themselves under the new PDPM, what PPS assessments will we have to do? We're down to 3. The 5-day has to have an ARD between day 1 through day 8, and it will pay for the entire stay. So no more figuring out when the rate switches to what it switches to. It's going to be consistent throughout the stay until they're discharged. And the only caveat to that is if you do an IPA. And that's the interim payment assessment, which needs to be done no more than 14 days after you've determined that the criteria have been met. So essentially that they're not coming back to their prior level of function within 14 days, and there's going to be a tier classification that's going to change payment. So you have 14 days from once you make that determination to do the assessment. The change of the payment days will be with that ARD through the end of the Part A stay, again, unless another IPA is done. And then PPS discharge assessment will end the and the payment, that's the last day in the stay, and is the third assessment that will be required. So a dramatic reduction in the number of assessments under Medicare. Another thing that they've introduced to the SNF world, but is not new to other post-acute care settings, is this idea of an interrupted stay and the interrupted stay policy, which they put forward in the final rule. And what this allows for is the restart of not only residence classification, but also the adjustment factor, the variable per diem adjustment for the classification and for the NTA. So basically what happens is if a resident is discharged from a SNF and goes out and comes back, but they come back to that SNF and it's before the end of the third day, before the bell tolls on the end of the third day at midnight, it's a continuation of the previous stay, and this interrupted stay policy doesn't apply. So you have 3 days, and if they get back to you and nothing has, and they haven't gone elsewhere, but they come right back to you within that 3-day time frame, you just keep going with the assessment that you have governing the rate of reimbursement, and then you would watch to see if an IPA is determined, but that stay would just continue. An interrupted stay happens when the resident's gone longer than that 3-day time period. So if they're gone longer than that three-day time period and they come back to you, the admission is considered a new stay. Or if they go to another SNF before that, is considered a new stay. So if they go out 3 days and come back to you after 3 days, it's a new stay. If they leave you and go to a new SNF, it's a new stay for the new SNF. The variable adjustment schedules resets to day 1. And so that adjustment applied towards your rate is reinstituted, as it were. And that window, that 3-day period, starts from the calendar day of discharge, so the day they go out, and counts the immediate next 2 calendar days. So it's another qualifier in order to get to the interrupted stay. The readmission back to your SNF, it doesn't matter. It doesn't have to be to an acute care setting. It can be, anywhere when they're gone and come back to you. So hospital, community, or other facility. And the consideration about whether or not, it's an interrupted for that length of time, it's only the time between discharge from the SNF and the day they come back, whether it's to the same or a different SNF. So now that we have all of those components sort of under our belt, let's take a look at operational strategy. So we start to think about all of the information that's in the technical guide that that was published, and the final rule that was published. Really what it kind of distills down to is that the data, by and large, for the most part, comes from the MDS. And the good part about that is it's a tool, it's an instrument that we've used for quite some time now. We're familiar with it. Many groups, most folks have MDS QAPI programs already established because of the importance of the MDS in our, day-to-day lives. It's in, the foundation, as everybody knows, for care planning. It's the source document for quality measures, and quality measures are included in all sorts of things. Quality reporting systems, it's what's on Nursing Home Compare and 5-star. I mean, we kind of know all those things. Reimbursement is derived from it, not only from Medicare, but also for case mix states, Medicaid. Some managed plans use that as well. So the concept that the MDS is, and the accuracy of the data, is nothing new. It's something we've been living with for quite some time, but it just brings it to the fore, and also sort of sheds a light on some other areas of the MDS that we might want to focus a little bit more strategically on. It's a big document. We can't look at everything all the time, but we can be smart about the elements that we, put on our regular QAPI review list, right? I think sometimes because elements weren't essential in in some of these bulleted points, they may not have gotten the same attention that they would have, some of the ICD10 coding, for example, on the MDS, perhaps. I know folks did triple check and they look at that information, comparing it to the UB, but knowing that it's really included and coded in a specific spot on the MDS is going to be something that would be a little bit of heightened awareness. But the good part is, again, the tool is well known to us and we have systems and processes in place right now. One of the things that we also want to make sure that we're looking at, not only for the PDPM process, but also in the event that you have an audit or a review, we want to make sure that daily skilled services are clearly documented in the medical record. We know that for therapy, it's 5 days a week, it's 7 days a week for nursing skill documentation. That has never gone away. Folks that have had post-pay reviews or pre-pay reviews are, painfully familiar with that, particularly if your therapy services were, deemed to be not medically reasonable and necessary. You fall back on your skilled nursing documentation, and then it's critical that it's there in the medical record, then it's appropriate. So refocusing on that and making sure that we're capturing that. And then, this section GG, it's a new section. There's new criteria to it. It needs to be, completed, or there's a separate penalty. And I know from some people that I've talked to that they had gotten penalized on their reimbursement because they had missing, they crossed the 80% threshold for dashed areas in sections of GG, which are part of the quality reporting program. So you want to make sure that there's focus on GG for, making sure it's not dashed, and so it's completed, but also because that's going to be important in the different case mix components, obviously. And then the other focus that you don't want to lose sight of is Section G for the case mix states. Section G is still important, and it can be confusing now because we're looking at two different measures, looking at different areas with different rating systems. So thinking about how you would incorporate that into your documentation or how you're going to capture that is important. We know I've talked to some folks that look at Section GD as potentially something that perhaps the therapy group, whether they're internal or external, would take responsibility for because it's similar to some of the ways they code residents now. And so there might be a familiarity there, the lift would be less, but that's not to say there aren't other people that have the opposite view. But they're thinking about that, how to be strategic and streamlined and efficient when you're gathering and collecting that documentation is going to be important. Also important, again, documentation to support the surgery in the prior hospital stay. Sometimes, we hear from folks that getting the information, that transfer documentation from a hospital is a challenge, that you can't necessarily see what the reason for the stay is, or it comes in it's much later. There's lots of challenges with, getting the information from the hospital. When it comes to regard to surgery in particular, certainly the family of the resident, if they're able, could be someone that would tell you that, I was in the hospital for surgery. That would be one way to document and solidify that you have that information without necessarily hospital documentation. You certainly can ask the resident, family, responsible others and document that in the medical record. And then also remember that the ICD10 code is the primary reason for the resident or the patient to be in the SNF. Now, of course, it's probably closely associated with the reason they were in the hospital, and it may even be for the hip fracture. But so you should, again, just because they can't send it to you doesn't mean you can't look at that resident, assess them, and make a determination as to why they would be in the hospital. Work with your attending to get that diagnosis. And then, it's not to say there's aren't opportunity for improvement in communication with the hospital as well. Looking at, again, having information in the medical record that supports the coding of the MDS is vital when we get to swallowing difficulties, mechanically altered diets. You can be sure that CMS has lots of information. We've been completing this section of the MDS for forever. So they'll be looking at, whether there's a spike in swallowing difficulties, and I'm sure ensuring that there's appropriate documentation to support that. Likewise with mechanically altered diet. So making sure that that's clear and concise in the medical record will be important. Also important is going to be, this, just because therapy isn't front and center in the RUG category as it was, prior, before PDPM, doesn't mean that the documentation doesn't need to support reasonable and necessary delivery of services. We still are going to need to know the days, the minutes, and the need, obviously, as I said, for skilled services. And the reason for that is because CMS will be tracking how therapies are delivered, and they're looking at a combined limit on group and concurrent therapy of 25%. So if you're delivering services that aren't, one-on-one, aren't individual therapy services, but you think that you're going to be moving to a group and concurrent methodology or delivery of services, which is very appropriate, just know that they're going to be tracking that 25% rating. So we've been delivering individual services to get folks into RUG categories now. There's no reason to believe that our residents are going to change dramatically in CMS's eyes, and so they're saying that we're really going to be paying attention to that. The other thing that you're going to be wanting to, think about is what's your process now for identifying and tracking a changing condition. Because remember, for your IPA, one of the criteria is that there's a change that's not going to resolve itself in 14 days. And also, has these other factors about changing the reimbursement because you've changed the first tier classifications. So first of all, being able to notice that there was a change and using that to start the decision-making process about whether an IPA is important or not is going to be essential. In addition to that, we still have this opportunity to do MDS modifications. If you are coding an MDS and you're getting the information together and sending it off, and you get subsequent documentation that falls within the look back period, or you realize that there was an error, you still can do a modification. So understand and plan that, particularly where things are new and we're focusing on some different areas and we might not get all the information as quickly or understand that we need to get it. Make sure that you know how to use that, how to perform those. And then also, use the resources to assist you. CMS provided a crosswalk for the ICD10 coding, and this idea of being able to predict what clinical category folks are going to get into. We've been looking at that very closely here at PointRight to see how we can, use that to help our clients. But it's available to you. You just go to the website here. That's you see on the screen, will be in your handouts. It lists, there's a zip file there, just open that up, and it walks you through step by step how to look for your ICD-10 code and see what category that they would likely go into. And then you can use that as a guide as you're starting to practice and get familiar with the ICD-10 codes that are important. And the other thing to do is to start planning now. I know a number of you have probably taken a good look at the RCS-1 information when it first came out, and if you had done some legwork or started some investigation, worked on documentation capture, any of those elements that you worked on under RCS-1 has not gone to waste. A lot of them were rolled into PDPM with some, nuanced changes or changes as far as the IPA goes and some of the other things. But the work that you've done is not for naught. Build on that. But I think the key is to really start plotting out your plan now. Start getting, see the end in mind, October of next year. Know what, think about the big rocks that you have to move as far as education and training goes. Start to get people into that mindset without losing track of where they are right now, of course. But start planning now. Get your ground game going, and it will serve you in good stead when you're at the end. But it's when we went through the last big change where they changed the tool on us, we had to do all this education and training, was a huge lift for the SNF provider community, and we got to the other side of it. And I think that this is another example of where you've got this, start planning now, look at your the residents you have in house, what do you need to do from a case mix perspective, the clinical competencies you might have to improve on to take care of folks who are sicker, because those comorbidities will make a difference. But you have this. You'll be able to master this just like you did RUGS 4. And now we'll open it up to questions. I do want to just let folks know that we have, this is, as I mentioned early on, an ongoing educational series. We hope it will be part of your planning in order to get ready for the new PDPM when it arrives. The next session, session 2, will be on, actually, this, I apologize, it's October 18th. So that's 1/8. And it'll be on non-therapy ancillaries. What does that mean exactly? So again, save the date for October 1/8. That will be in your handouts, the correct date, and that will be the next session that we'll be having for you. And then lastly, for your CEUs, we will email you a link to the email that you provided when you signed up, and you will get an evaluation survey. If you don't get it for whatever reason, check your spam, of course. Sometimes it winds up in spam. Or you can go to the website here for SurveyMonkey. It will be in the handouts. And click on that, fill out the evaluation form online. Everybody who wants the CEU has to complete the survey separately. So if you want your credit for continuing education, complete that. You can forward to a friend. There's a link at the bottom of the evaluation. So if you're all watching it together or one person signed up and there's a bunch of people, then just click on that and send it over and they'll be able to fill that out. And so your certificates for the nurses will be available after download, after you complete the survey. And then for nursing home administrator licenses, you have to you have to provide your NAB number. So evidently that has to be entered into the system. That goes to a registry, so it gets recorded at a national level for tracking that. So with that, I'm going to take a look here, see if there are any questions. Scroll up here. So one of the questions is when we're in nursing case mix, what's the definition of ventilator use? Does this include those folks who are not vent dependent, but who go on the vent at night for rest? So the definition of the ventilator patients hasn't changed at all from the traditional definition, so that will stay the same. So when they qualify for ventilation use, when the look back period, you would just check that off on the MDS and it wouldn't change. So if a vent is in use, you would get credit for it. There's another question here that says, when does the new payment due to the IPA go into effect? So when you complete an interim payment assessment, the payment change will go into effect on the ARD. Now, of note is it does not change your adjustment factor or your variable per diem rate. So you know that when folks are in the course of their stay, there's an additional case mix adjustment called the adjustment factor that has to do with where they are in the stay, and that does not reset with the IPA. It only resets when an interrupted stay has been determined, and then that was when it would start over. So that's the IPA question. If a resident meets the criteria for an IPA, which means something has changed, then do we need to complete a SIG change with the IPA, or do we go by the RAI manual, which states you have to have a change in 2 areas versus the IPA, which requires 1 change in the first year? So yes, thank you for pointing that out. It is going to be confusing. SIG changes will follow the SIG change rules in the RAI manual. So it's got to be more than 1 area and has to not resolve in 14 days. The IPA is different. It's going to not resolve within 14 days, but also create a change in their first tier categories. So they're two different ways of determining whether a SIG change it's different whether a SIG change needs to be done or an IPA needs to be done. I was only drawing the correlation because of that 14-day time frame. And so if it looks as though someone is not going to revert within that 14-day time period, you might want to consider if a SIG change is due or if you've met the other criteria for an IPA as well. Good questions here. Okay, can you clarify for interruption of stay, if they DC to another SNF but return within 3 days, is that considered a readmission? So if they go out for interrupted stay and they come back to, if they go to another SNF but come back within 3 days to the first SNF, it's not an interrupted stay for the first SNF. So remember, it's the day they left your SNF and the day they came back. If it was 3 days or less, it's a continued stay. If it's over 3 days, it's a new stay. And it matters not where they went, it matters that they were out. In this case, if they went to another SNF, the other SNF, excuse me, would have a new stay and then a discharge. Question about when will the archived audio be available on today's session. It takes, I think it takes about a week or so for the to sort of tie up the recording, get that all packaged up, and then posted. So about a week or so. Let's see here, a couple more minutes. Is the time frame to complete the admission MDS the same time frame as the RUGs? So yes, the grace days are rolled into under the new PDPM. When you do your 5-day, it'll be day 1 through day 8 are the ARDs dates that you can select as ARDs for that assessment. And then the PowerPoint, couple questions on the PowerPoints, those will be available. They'll be sent out to you, I believe, with the emails, and they will definitely be stored for clients on the training academy website for PointRight. Question about when will PDPM start? So not this October, but the following October. So October of 19, which is fiscal year 2020. Question about, is there a limit to the amount of IPAs that one can complete per patient? Nope, they did not indicate, CMS did not in the final rule or in the technical specs indicate that there was a limit to the number of IPAs that could be done. So that's that. Will tracking assessments still need to be completed if a resident is out less than 3 days? The rules and regulations regarding the requirements for OBRA have not changed at all. So that will be the same. If you needed to do a tracking assessment when they left your building, you'll need to do a tracking assessment now under PDPM. The only thing that will change is the 5-day assessment that will be done with an ARD of day 1 through day 8. A PPS discharge assessment that will be done when they're no longer on Medicare or they've discharged from your building. And then the voluntary IPA assessment. And there, we have one more question. The interrupted stay does not go by what the DC type is, whether or not it's return not anticipated. That is correct. Interrupted stay is only, when were they in your building? What day did they leave your building? Were they gone more than 3 days or less than 3 days? And then you would know that you could do that interrupted stay policy was important, was able to be. It's considered an interrupted stay. All right, so it's straight up 3 o'clock. Thank you so much for your attention and all the great questions. And hope to see you on the 18th for the next session for the PDPM PointRight training.